Hello guys, today we're going to study short bowel syndrome. So here is a brief introduction of what short bowel syndrome is. We can define short bowel as presence of less than 200 centimeter of residual small bowel in adult patients. It means if a person has small intestine less than 200 centimeter in length, that person is going to have short bowel and he's going to experience all the signs and symptoms of short bowel syndrome. As we know that small intestine is involved in the absorption of food. So when there is short bowel, that person will be experiencing malabsorption, which will be manifested as diarrhea, dehydration and malnutrition. On average, if 50% of the small intestine is resected, it will be well tolerated by the patient. But if 50% to 80% of small intestine is resected, that person depends upon total parenteral nutrition for his survival. So what are the causes of short bowel syndrome? Causes might be some infection, some trauma, Crohn's disease, midgut volvulus, fistulas, short bowel tumors, radiation arthritis, and ulcerative colitis. So all these causes might lead to development of short bowel syndrome. So what is the pathophysiology of short bowel syndrome? Short bowel leads to hypersecretion of the gastric hypersecretion, and that gastric hypersecretion might lead to acid diarrhea. As we know that short bowel syndrome leads to electrolytes and fluid loss, that person might experience some signs and symptoms of dehydration. Then our gallstone formation. As we know that bile salts are not absorbed and cholesterol is precipitated, which leads to gallstone formation or cholelithiasis. Next is hyperoxaluria and nephrolithiasis. Normally, calcium and oxalate binds in the bowel to form insoluble calcium oxalate complex, which is excreted in the feces. But in short bowel syndrome, calcium binds with the fatty acids. So oxalates remain unabsorbed, unbounded, and then are absorbed from the colon. This causes increased oxalate level in circulation, leading to oxalate stone formation or nephrolithiasis. Then is diarrhea and steatorrhea. As fat is not absorbed, it results in steatorrhea and diarrhea. Vitamin B12 is absorbed basically in terminal ileum. When there is short bowel, vitamin B12 is not adequately absorbed. It leads to vitamin B12 deficiency. So here's the treatment of short bowel syndrome. The patient is given fluids and electrolytes. He will be provided with the nutritional support in H2 blockers, which are actually the proton pump inhibitors, and they decrease the gastric acid production. Then other antidiarrheal drugs such as loperamide is given to these patients. As far as surgical treatment is concerned, the aim of surgery is to increase absorption by slowing the motility of the small bowel or by increasing the length of the small bowel. So the motility of the small bowel can be decreased or slowed down by one of these methods. Number one, segmental reversal of small bowel. Number two, interposition of colon between segments of small intestine. Number three, we can also make a small, weak intestinal wall, which results in slowing the motility of the small intestine. Then we can increase the length by intestinal transplantation. This procedure, intestinal transplantation, is now being increasingly performed to treat patients with a short bowel.